so much. You guys have to keep on me about that. I record so much that you'd think I'd remember that. Okay, so you need to ask probing questions, and not just go through their medical history. And one thing that I like to ask is they have something like allergies, and they have marked allergies, and I'll say, tell me about your allergies. Okay. And so let them do the talking, and then it doesn't seem, you don't have to run through, 15 different allergies, and they don't have those to those, but they have an allergy to something else. But they don't tell you that because you didn't ask that particular question. So we always ask probing questions. Some of the things on medical history conditions may include if someone says that they have heart conditions, we need to be alert to a possible myocardial infarction, which is an MI, which is a heart attack, congestive heart failure, a CHF, or a cerebrovascular accident, which is the medical term that they call a stroke. So if they mark down asthma, of course, you need to be alert that they could have an asthma attack. If they mark down a stroke, they could have possible frequent headaches or dizziness. And so we need to be aware of them, orthostatic hypotension or something with them. And if they mark down epilepsy, you need to be alert that they could have a possible seizure while in the chair. They mark down thyroid problems. We need to be alert to hyperthyroidism or hypothyroidism, which is myxedema coma or a thyroid storm, which we will get into in the second half of the class, or maybe the end of the first half. I don't remember. So if they mark diabetes, we need to be alert that they could have hypoglycemic effect or go into a diabetic coma. So if someone marks diabetes, I'm going to say, what type of diabetes, type 1 or type 2? And that gives me an indication right there of some things that you will be learning that we need to be alert to. And if they have, then I would ask, did you eat breakfast this morning? Did you take your medication this morning? And you'll be surprised. Most of them will say yes, but you'll be surprised at the number that go, no. They got up late, they hurried to the office, and they didn't eat, or they didn't take anything. And stress can bring on some of this stuff too. So we always have in Dr. Thurlow's office, we have breakfast bars or something that we make them eat and give them some juice. So we always know where those are to be able to give them, and then we let them eat a little bit, even like half of it or something, and then we'll go ahead and start the appointment. So if they have corticosteroid use, they may have adrenal insufficiency, which there's a chapter over. An allergy to something, you need to be alert to an attack or some kind of skin reaction, or even depending on what it is. If they marked allergy, you could say, tell me about your allergies. And they could say, well, I'm really allergic to latex. And then I would say, how does it manifest itself? And they would say either, oh, I get a skin reaction like hives, or my throat closes shut. Well, those are very two different things that could be possibly life-threatening. So we need to know where our EpiPen is if they go into anaphylactic issue, and etc. So anyway, if they mark bleeding disorder, then we would want to know, tell me about your bleeding disorder, or your bleeding problems. And then they'll go ahead and say, well, I bruise super easily. I'm a hemophiliac. We've had students before who have hemophilia, and so they're missing a certain gene that helps to clot the blood. So it truly helps that if they get cut, depends on kind of how severe their case is, because if we're going to give anesthetic and pierce the tissue and be scaling around, they could be bleeding and bleeding and bleeding, and then it's hard to stop. We need to be aware of that. So mostly that's going to affect the dentist if he's extracting a tooth, etc. So, and they could hemorrhage because of that. Hemorrhage is just, the blood just keeps coming out. So positive response, if they mark a positive response on anything, then this is what it's saying. We need a further dialogue with the patient. And it doesn't need to be 15 minutes long, but you just need to go through a few things, and you'll be learning that, and you'll be an ace at it by the time you get out of the program, and really way before that. What you need to know with the dialogue is the frequency. Like if they have asthma, how often do you experience an attack? Oh, only during ragweed season. Well, then you don't have to be so afraid that they're going to have something in. I mean, they could, but you don't have to be so afraid. If they say to dust or whatever that may be in your office, then you need to be more aware of where is, if they have their inhaler, and where your inhaler and your emergency kit is. It's the severity of it. And I think I already spoke to that. How severe is it? And what triggers it? So the frequency, the severity, and the triggers are three things that you need to ask. Do you use an inhaler or a nebulizer, or do you need to go to the hospital when this happens? So some people will say, the inhaler or nebulizer don't do it for me, and I have to go straight to the hospital. Well, that is a different situation than someone saying, oh, my inhaler takes care of it, and that's fine. And then you want to ask them, do you have it with you? It's always better, even with nitro, with heart issues, and maybe they take nitroglycerin. It's always better if they take it their own. And there should be someone in your office, like we have at our clinic, that goes around periodically and on a set schedule and checks the expiration date of things in your emergency kit, because you can go, and we didn't hardly ever have to get into our emergency kit in my private practice. So it can be forgotten. You remember where it is, but you can forget, to go in and check. So if someone's having an issue, you don't want to go in there and someone forgot, oh, they're so sorry. Well, and now they're taking medication that's no good. So it's always better if someone has their medication with them. They're more likely to have it and not in an expired situation. So we want to say, are you on medications? Did you take your meds today? Did you eat today? And so you may need to postpone, depending on what the issue is, or at least modify the treatment. So there's 4 vital signs that are taken everywhere, and it's pulse, respiration, and blood pressure, and smoking. I'm sorry, what are we doing? I'm sorry, temperature. However, we don't do that we do now, don't we, in COVID days, but normally before COVID, people didn't take a temperature when you go to the dental office. So we were just using pulse, respiration, and blood pressure. So on tests, you would say pulse, respiration, blood pressure, and temperature, and they came up with a new 5th vital sign, which is smoking, because smoking does a few things. It can prohibit the healing process. It will take a lot longer, and it could have issues of breathing, respiration, and stuff like that on its own. So they've made that into a 5th vital sign. Irregular vital signs are an indication of a possible emergency. So you have tachycardia, bradycardia, tachypnea, bradypnea, or dyspnea. So let's split that word. I wish I could use, tachycardia is heart. The last part of that word is cardia, tachy and brady. And tachy and brady are the prefixes. Tachy is fast, something that's faster than normal. Okay, bradycardia is something that's slower than normal. So pnea, the next 2 words, P-N-E-A at the end of those words, the next three words actually, is breathing, something that is doing with breathing. So tachypnea is faster than normal breathing, like hyperventilation would be tachypnea for sure. And bradypnea is slower than normal breathing. Dys in front of any word, DYS, means difficulty, like they're having difficulty breathing. You're not sure which one, they're not really showing faster or slower. They're just having a great deal of difficulty. So that will be it. And it'll be discussed some more. So then we go to the ASA classifications that you'll be dealing with. Now in a private practice, we never dealt with ASAs on any practice I was ever in. You may get to a practice that decides to do that. So, but certainly in the clinic, and we have to do this and classify by ASA. Hospitals do this, the medical field, and we will do it in the clinic because it can give you a big clue as to what's going on. ASA is a classification of their physical health or their condition. So we have from class 1 to a class 6. ASA stands for American Society of Anesthesiologists or Anesthesiologists. So what does that have to do? The reason that this ASAs were even born at all was because there are certain conditions that you have to be really careful of giving certain types of anesthetic. And there's certain medical conditions that people have that we don't give an anesthetic to them, or we have to change the type or the amount that we give based on what they have. So they came up with this health classification to immediately help know what classification a person is in. So patients with a higher classification, type 3 and higher, have a much greater risk of a medical emergency and have some stipulations on the types of anesthetic that they can have. ASA classifications were amended back in 1962, and they're still used today. Let's look at an ASA1, which would be a normal, healthy patient. They have no organic, physiologic, or psychiatric disturbance. This is going to exclude the very young, 3 and under, and older, 60 and older. Anyone between 3 and 60 that is healthy and with good exercise tolerance, and they're not on any medications at all, don't have any health issues, would be ASA1. So they could have any kind of anesthetic. If they're not taking any medication, mostly it's this, but there are a few exceptions. They allow someone that's taking birth control to be in an ASA1 category, vitamins, or seasonal allergy medication. So if you're just taking allergy medication or you just need your inhaler truly only in ragweed season, the spring and the fall, then you could still be a 1. But if you're taking your asthma kind of regularly, you're using an inhaler regularly, or you're taking meds, something on a daily basis, then you're not an A1. You would be an A2. So A2, ASA2 would be anything that's mild systemic disease or a risk factor for systemic disease. This person has no functional limitations and has a well-controlled disease. So, or is on some type of medication, even if they don't have any serious systemic diseases. So this person has to have at least one of the following. They could have controlled hypertension, which is higher than normal blood pressure, high blood pressure. Type 2 diabetes without any, like it hasn't affected their liver or kidneys or any organs. So that would be that person. If you smoke at all or you vape a lot, you are automatically in an ASA2. But the person with COPD is higher classification. This would not include COPD. If you have mild obesity, someone who comes in that's pregnant is going to be an ASA2. And what that's telling the clinician is that this is an ASA2 person you need to delve into, in case you haven't already, why they're an ASA2, and if they're pregnant, what anesthetic they can have and what anesthetic they shouldn't have. Mild allergies, anyone 60 and over is automatically an ASA2 unless they have bigger health issues, which would push them into a higher category. Age 3 and under, which we don't have to worry about seeing anyone under 3 for SRPs or giving anesthetic to, but they would be a 2. If they have mild dental anxiety, and this is not the person who is like crying in your chair, which we have had before. This is the person who says, it's more than just saying, I hate coming to the dentist. Okay. What you're noticing is when they're white knuckling the armchair with their fingers. You can see blanching on their fingers because during the whole thing, and even if they're being quiet, they're kind of sweating, they're anxious, and they're real talkative. And people tend to a lot of times talk a lot when they get anxious. This person would be in an ASA2 because it does matter if we use epinephrine in an anesthetic. If someone is really, really anxious, the epinephrine in the anesthetic, if you choose that one, could help even excite their heart more. So that does make a difference. If they're doing any psychiatric care, they're on antidepressants or anything like that, then we need to know. So number 3 would be a severe systemic disease with some functional limitations. It limits their activity, but not incapacitating. Maybe when they're walking up flights of steps, they can't just, like a 1 could just go up the steps, maybe tired, but they could go up a lot of steps. And a 2 may go up, but just a teeny bit slower, not a big deal. A 3 is going to go up maybe a lot slower and kind of be breathing really deeply. It's not going to keep them from walking, but they have some limitations. This person could have a controlled disease of more than one body system. So maybe it's controlled, which would put them usually in an ASA2. But it's not just their liver, it's also their lungs. So then we go up to a 3, but they're not in any immediate danger for death. Controlled heart failure, stable angina, myocardial infarction, which is a heart attack longer than 6 months ago, but they have no signs or symptoms. So if they say they put heart attack, and you say, tell me about your heart issues, and they say, well, I had a heart attack 9 months ago. Well, how are you now? I'm fine. This person would be already an ASA3. Okay. Controlled type 1 diabetes. Type 2 diabetes would be an ASA2. ASA3 is a controlled type 1 because the ASA3 type 1 has to have insulin on a daily basis. ASA3, poorly controlled high blood pressure or hypertension, greater than 160/100, which would be a stage 2 hypertension. If they are morbidly obese, if they have chronic renal failure, which is liver, poorly controlled asthma. A 4 is someone that's incapacitated. They are incapacitated systemic diseases that are a constant threat to life. This is the person that has really severe congestive heart failure. They could be in a wheelchair and have to have oxygen on them. Their fingers are, nails are kind of bluish. Their lips are kind of bluish. They're not getting enough air. They could have a shortness of breath, of course, distress even at rest. This is or a person who has had a heart attack or a myocardial infarction within the past 6 months would automatically be there. And next time they come, if it's past the 6 months, they could go down to an ASA3. So this is not something, your health doesn't stay stagnant, or static. It could change from time to time. So all of a sudden, you don't take, as you took all the shots and you don't have allergies anymore. Okay, so you could go from a 2 down to a 1. Most of the time they kind of stay the same, but they could be different. It's how they are when at the time you're seeing them. because that's the time that you possibly could be giving them anesthetic. Okay, so unstable angina or heart, pain in the heart. Symptomatic heart failure. COPD someone who has COPD is going to be an automatic ASA4. Hepatorenal failure. Renal is kidney. Anything hep or hepa is liver, and the O is just in between those two nouns to connect the word. So hepatorenal failure. ASA5, this is a person you're not going to see unless during your lifetime and career they will really start allowing hygienists to go more into the hospitals. And this is going to be a moribund, which means bedridden patient, not expected to survive 24 hours without an operation. So if this person, even in the hospital, you would not be seeing, if they don't expect to survive in 24 hours without an operation, they're not caring about their teeth. So ASA6 would be someone who is brain dead, whose organs are being harvested for donation. So preparation for a medical emergency in the dental office, you need to have a well-equipped emergency kit with oxygen, a current CPR training, attendance at continuing ed or CE courses on medical emergencies, and have some in-office simulated medical emergencies in your office. So they came up with, in this book, different offices will term them different things, but they have some kind of a systematic way of having a team structure. They'll call them like one per P1. P1 would be the clinician who's operatory the emergency, that your patient's having the emergency. So we don't ever yell code blue or anything ever in our clinic. Your offices might say something like that, but we don't in the clinic. We stay with the patient and we perform the emergency procedure if it can be performed without EMS being there. P2 is the next most available person. They're going to assist P1. So I'm going to, if it's in the clinic, you're going to get the instructor. That's going to be your person, and the dentist comes out, etc. But if you're in an office situation, the next person who's in the operatory next to you or who happens to be walking by, they're going to say, I'm having an emergency, and you're P2 or you're person 2. They're going to assist you. They're responsible for taking the vital signs and the application of putting oxygen on if they need it. They're going to record the events and inform the clinician of the time elapsed since the medication was delivered. If it was an aspirin or if it was, albuterol or whatever it was. Then there's P3. That's going to be just the very next available person. They're going to be the one that retrieves the emergency kit. So another person comes up to your door because they're hearing this commotion going on, and you're going to say you're person 3. So they're going to go in the other room and find the emergency kit, and they prepare emergency drugs for patient 1, of which we can give very little. Then you have the office receptionist or administrator, who could be person 4. They're going to make all the necessary calls to 911 or the doctor so that you don't ever have to leave the patient. Any questions over that?
I have a question.
Sure.
On the study guide on question 11, a few of us were confused. What ASA category has both well-controlled type 2 diabetes and stable, I don't know the word though.
Angina.
Yeah.
If it'll be on page 3 in your text, there's a whole list in page 3. This is you'll find the answers in the text and also on the PowerPoint. So you will find a whole list on table 1.1 of your text, which gives examples of conditions.
On that text, it only says that ASA 3 has stable angina, but that has type 1 diabetes, not type 2 like the question asks.
You mean in the text?
Yes.
Okay, I see controlled type 1 diabetes. Oh, wait a minute. Yeah, controlled type 1 diabetes. Oh, I see what you're saying. Okay, that should be unstable angina.
It's asking for type 2 diabetes.
Yeah. The question on number 11 should be know what category. Hold on. It is asking for 2.
So wouldn't it be ASA2?
Yeah. But stable. Yeah, yeah, that doesn't make sense. Okay.
I just listed them out, like type 2 diabetes is ASA2, and then stable angina is ASA3.
Yeah, that would be in answer to that question, yes. But I think I meant it that they had both, so I should have said unstable angina and well-controlled type 2 diabetes.
So do we for that as unstable and well-controlled type 2, or do you want us to keep it answering it as like 2 parts, stable and then type 2?
Yeah, go ahead and do that, and then you'll just remember it better that way. Thanks for pointing that out. I'll fix that on the study guide. Okay. So the emergency kit. The emergency kit, the big things that you need to know about the emergency kit, whether I have it on the study guide or not, is that I've seen it tons in review books. What is the best emergency kit? You need something that's custom designed for your office, and it needs to be very simple. It needs to be economical and super easy to use, because if you get a kit like the one that they have in that picture and give a 15-minute rundown on how to use everything and you don't need it, nobody's, 4 months down the road when there's an emergency, nobody's going to know how. It's too complicated. People don't know how to use what, and then they're scared to use it because they're not sure that if they remember it correctly. So if you're making an emergency kit for your office, it would be good to get a list of everything that would go into an emergency kit, and then pick from those what would be appropriate for your office. So, and it can be, it should be this, the simpler it is, the better, because if it's, and they just won't use it. And so what good is it? So, it needs to be mobile. You need to have easy access to oxygen. And you always consider your location. If you, like I said in the clinic this week, if you're in the city, we're surrounded, our clinic, with hospitals. So we're going to have EMS pretty quickly. But if you're out in a rural setting, then you probably need more in your emergency kit. Oxygen, we use oxygen for all emergencies. That's, I see that in review books all the time, except for hyperventilation. So if someone is getting too much oxygen, you're not going to put more oxygen on them. They're like breathing heavy in oxygen, and we'll go through that on our in a later section. This is a size E, like we have at our clinic. It's 30 minutes of oxygen, and it's portable. In my private practice and most private practices, it is it goes through the walls, and you have access to it in your operatory. So
will all of the size E's be green? Because on question number 25, it says know the color of the oxygen tank and how many minutes a size E cylinder provides. So we would put green and then 30 minutes of the oxygen, correct?
Correct.
Okay.
All size E's in the United States are green. Oxygen, no matter what size the tank is always green. Could be a bigger tank. Okay. Essential drugs that you need to have in there would be epinephrine. Another word, it's also known as adrenaline. It's also a hormone and a neurotransmitter. It's clear, it's colorless. It's for, you give epinephrine like the EpiPen. You give it for the most severe form of, which is anaphylaxis. And it acts very, very quickly. It just doesn't last that long. So you have to sometimes give it over like every 5 minutes or so, not to be exceeding 3 times in 15 minutes. It's going to immediately reduce their high blood pressure or bronchospasms. Reduces their low blood pressure, their bronchospasms, any kind of laryngeal edema. Edema means swelling, and could have pus or something with it. In this case, it's just swelling of the larynx, laryngeal. That's their throat closing shut. It prevents additional release of histamines and other chemical mediators from our system. So here's an EpiPen. I will give you an EpiPen probably during 101, and I want you all to, it's a trainer, to see how the force that you would put it on someone's leg. They have a child EpiPen and an adult EpiPen. So epinephrine is the thing that they use for anaphylaxis. An adult dosage is 0.3 milligrams of a 1,000 solution or ratio. So we'll go through and explain what all that means at a later point, but it's just something that we memorize. I see this on tests all the time. What's the adult dosage? So it's 0.3 milligrams of a 1 in 1,000 ratio, which is how you say 1:1,000. So a pediatric dose is half of that solution. It's a 0.3 milligram of epinephrine in a 1 in 2,000, which is, it looks larger, but it's actually smaller. Okay, and so we're always going to follow giving them an EpiPen or epinephrine with a histamine blocker. So epinephrine is a very severe asthma attack. You can give it for that too. You should not use if the person has ischemic heart disease or very severe high blood pressure. It's like over 200, very severe. Doses can be repeated until the anaphylaxis symptoms subside, because they don't last long, but usually by the time EMS can get there, hopefully you've just given, it's about 15 minutes and you've just given 3. You need to have nitroglycerin, nitro we call it. This is going to reduce the blood pressure. People that have pain in the chest, angina pectoris, or heart attack or congestive heart failure, what nitro does super quickly is it will dilate the coronary blood vessels. These are little tiny blood vessels that are on the outside of your heart, and they immediately dilate them, letting more blood and oxygen through, which is what you need. Rapid, you can get it in a tablet or a spray form. The tablets become impotent or impotent if they're exposed to light or air. So a lot of times people will use a spray. You have to make sure that where your emergency kit is kept. The shelf life is reduced to only 12 weeks before it expires if it's exposed to air. So a spray shelf life usually is about 2 years. So 1 tablet of nitro would equal 1 spray. We have both. So this would be what nitroglycerin pump spray would look like in an emergency kit. So you administer this sublingually, which is below the tongue. Administer at 5-minute intervals up to 3 doses. So for every 5 minutes for 15 minutes. You should not administer that if their systolic blood pressure is less than 90, because if they already have lower than normal blood pressure or hypotension, so you don't want to give them something that's going to further lower their blood pressure and then they get to 60, which can be super dangerous. Then you have diphenhydramine and chlorpheniramine, and what these are big words for Benadryl and chlortrimeton that you can buy in the drugstore. So you need these for allergic reactions, moderate allergic reactions with any kind of respiratory, hard breathing, mild non-threatening allergic reaction. So they're histamine blockers, and it just gives the dosage. I've never seen anything really ask what the dosage of those two are because it's always on the package. This could be what it looks like. And they also have an injectable, and it's intramuscular histamine blocker of both diphenhydramine and chlorpheniramine. So then the pediatric dose should not exceed an adult dosage. Benadryl, though, causes drowsiness, as we probably all of you know, and chlorpheniramine, it does not. This is what an albuterol inhaler box looks like, and then you use this for asthma attack or bronchospasm inhaler. It dilates the bronchioles inside your lungs, and it has very minimal effects on your heart, on the blood vessels of your heart. It's a super quick onset. It peaks it'll peak the very strongest at about 30 to 60 minutes. And it has a long duration for these type of drugs, meaning it can last 4 to 6 hours. So they consider that long versus like nitro, which doesn't last long at all. The adult dose is you always give 2 sprays, and pediatric dose would be 1 spray, and you can repeat the dose if necessary. So on children, they a lot of times use a spacing device. They'll put the inhaler, which is in yellow, in the end of that spacing device because they don't know how to breathe right when they press it down to make sure that it goes in their lungs. And so they'll breathe and then hold their throat closed when it's spraying out. So it's all over their palate and teeth, but it's not down their lungs. So they put this in and just have the child breathe through here just normally for a while. So all that until they think it's all gone from there. So aspirin. Aspirin reduces overall mortality from a heart attack or an MI. It prevents the progression of cardiac ischemia and cardiac injury and cardiac tissue death. The recommended dose is 162 to 325 milligrams. I would know that. Whether it's on the study guide or not, it's everywhere in books and midterms and everything. It's taking 2 to 4 baby aspirin. Baby aspirin are usually 81 milligrams a piece. It might say 0.81. So if they're 81 and you take 2 of them, it's going to be 81 times 2 is 162. If you take 4 of them, it's actually going to be 324 milligrams. But if you're taking that many, they kind of up the milligram to at least 1 more. So it's not a typo. The actual dosage is 162 to 325, even though if you times 81 times 4, it's 1 milligram less. So they're not trying to trick you. Check your medical history for an allergy to aspirin before you give someone aspirin. An oral carbohydrate, this hypoglycemia, this is when they have lowered emia at the end of this word, means blood. Hypo means less than normal, and glyc is sugar or carbohydrates. So this person has less than normal sugar in their blood, and that's hypoglycemia. This is for conscious. If they have not, you can give them one of several of these, or we give them a breakfast bar, or you can give them juice or sugar cubes, whatever has a long shelf life. And sugar cubes really have the longest shelf life. But most of the time people will give a juice box or something like that. Paste and the tablets don't require refrigeration. These are not actual drugs at all, but you need to have them. So this is a drug. It's an extra drug that you could have. It's glucagon. This is a hypoglycemic patient that has less than normal sugar that has fainted. So obviously they're not going to be able to chew anything or eat it. They would need to be injected with it, and glucagon is what they get, and it's administered intramuscularly. People that are that when they have their meds and they write down, I'm taking corticosteroids. This corticosteroids could cause an adrenal crisis. Your adrenal glands are on top of your liver, and we'll go through in a later chapter kind of what the issue is there. But corticosteroids, if you give a person a histamine and for allergic reaction, and then you give them a corticosteroid after it, it will prevent the recurrence of anaphylaxis, because an anaphylactic episode could repeat itself in, like, I don't know, 6 or 12 hours. You could have another episode. Doesn't mean you're going to, but you are predisposed to have another occurrence of it. So if they give a corticosteroid after that, it will prevent that recurrence. So there's a slow onset, greater than 1 hour. So it's not a great thing to have for something that you need immediate relief for, but it's going to reduce the histamine release, and so it's good just to have in your kit. This is Solu-Cortef. This is a hydrocortisone, which is what they would need if it's going to be given intramuscularly. And I remember this word on my boards way back in the 70s, Solu-Cortef. So they still have that around and still use it for that. Injectable benzodiazepines. These prolonged seizures are for hyperventilation. It's an anticonvulsant drug, or it has a mild tranquilizer effect. So it gives muscle relaxation. And so if someone is seizing or they're hyperventilating and we need to relax them, they could get an injectable benzodiazepine by EMS. Lorazepam is the drug of choice. We have it in our kit and have it ready for medical doctors or possibly your dentist to administer. And they get 4 milligrams intramuscularly. Other names for lorazepam is Ativan, Valium, Xanax, Klonopin, Versed. They're all brand names for the same thing. So this would be lorazepam injection that you would have put a needle into. These are additional items. Of course, blood pressure and stethoscopes. Have a pediatric, a smaller cuff, a large cuff, an extra large cuff, because if the person if they have a big arm and you are just putting a medium cuff around their arm, that's squeezing it to death before you even pump to purposely squeeze it, they're going to have higher blood pressure. And if you put a normal adult cuff on a child, it's not going to, with a really skinny arm, it's not going to give you a true reading either. So these are pocket mask items with a one-way valve that's good to have in there. This is a perio retriever, just as an emergency kit. This is those ends on these instruments are magnets. And so if you break off a tip in the sulcus or in the mouth, you need to retrieve it, or they have to get an x-ray. So you don't want any of that swallowed. That could be really dangerous, and we'll go through that in a later chapter. But this is a magnet that you can put down in the sulcus and get the tip back. So additional items, ice packs for bruising or swelling from anesthetics, extra syringes, thermometers with sleeves, an AED. We have one on the first floor of that tall building on at our school, and we now have one in the 4th floor stairwell. So you need to know where those are located. And we have assorted bandages and gauze.
An AED is a defibrillator.
Okay. There's a few things I'm going to go run through this, and then you're going to, because we're not going to have enough time to finish everything. I'm going to run through this really because we are going to be covering this again, vital signs in 101. So it's kind of redundant. We need to take baseline vital signs and for comparison and have them in our notes. They are going to determine the body's ability to pump the blood, to breathe, and also determine the health status. So there's 4 vital signs. Once again, pulse, respiration, blood pressure, temperature. Smoking is the new 5th one. Weight is not considered a traditional vital sign. I have seen some recent literature on them wanting to make weight a vital sign, since Americans have a problem with obesity. They haven't as of yet. So, but in a pediatric office, they will take weight. But a lot of times in regular offices, people don't like their weight taken in when they're going to the dentist. So the speed of the heartbeat is the pulse. It's the expansion and contraction of an artery as blood is forced out of the heart muscle. So what it is, well, let me get to that later. It's felt where the artery lies close to the skin surface and it's compressed over hard structure, bone, or muscle. So your pulse is going to be on your thumb side, and you want to have more than one finger on it. Like I'll go like this and take it like that. You can, on your usual sites, if there's a medical emergency, like you're out and about or someone drops down on the street beside you and you want to take a pulse, the carotid is always used for that, which I think we went through in the CPR class. The radial pulse in the wrist is what we're going to use. And there's a brachial pulse in the arm for infants, and there's a femoral pulse in the groin area. Most common site in a dental office is, of course, the radial pulse. So this is them taking a pulse. Normal pulse rates, a healthy adult is 60 to 80 beats per minute, or it can say 60 to 100. Sometimes they will say, it might even say 60 to 100. Sometimes if you have a healthy person, I've never seen anyway on a test multiple choice that will say, is it 60 to 80 or 60 to 100 or 80 to 100 to goof you up. They'll either say 60 to 80, 60 to 100, something like that. So it shouldn't be, just know those, that the parameters on the high and low would be 60 to 100. Okay, so individuals who exercise regularly tend to have a lower pulse. So that adult who exercises regularly could have a pulse of only 40 to 60, and that's normal. So respiration rate, you can go by RR. It's the number of breaths per minute that you're going to watch the chest rise and fall. And the first, you count 0 on their first one. So you want to see them inhale and exhale, and that's 1. Okay. And then inhale, exhale, that's 2. So infants and adult children rate is quicker. Newborns have a really fast respiration rate. They will do 40 to 50 beats per minute. And as the chest cavity and lungs get larger as the child is growing, it gets shorter and shorter. An adult is 12 to 20. Now, our Wilkins book, I think, says 14 to 20, and this says 12 to 20. So on any of my tests, I will always put the lower of the two, 12 to 20. And we're just going to call that good. And your office needs to decide on a number kind of as well, but I'd rather take the low and the high and leave it that way. It's really irritating.
So on number 18 on the study guide, it says it wants the normal, so that would be 12 to 20, and then higher than normal. Would that be anything over 20?
Correct.
Okay.
And they're breathing on that, so they'd have tachypnea.
Okay.
Okay, so respiration rate, apnea. A before any word means usually not or none, not at all, or in this case, absence. So apnea means absence of breathing because pnea means breathing. If it continues, it results in respiratory arrest. You cannot sustain life as the brain requires oxygen, we all know. So I've seen this next in questions. It may even be on my midterm or final. Oxygen deprivation of 10 minutes or longer leads to coma or death, which is brain dead. So I usually see brain. You can have your brain dead when you're deprived of oxygen for how long, and it would be at least 10 minutes or longer. So immediately following the pulse, so the patient is unaware and is not controlling breathing, you're going to move the patient's arm over their stomach and continue with the pulse. And this is because if you tell someone you're getting ready to take numbers on how they breathe, they all of a sudden don't breathe normal. So we move the patient's arm and over their stomach and just pretend that we're going to take a pulse again, when we're really looking at respiration. And if they, in the wintertime, when they have on sweaters and everything, you can't always see, but if you have their arm over their chest, over their stomach area, and you're pretending you're taking a pulse, then it can kind of go up and down, and you can get the pulse better. So count the number of times the patient's chest rises in 30 seconds, and then multiply that by 2. If, however, you can tell that their respiration is really irregular, it's not going in a normal, regular beat, it's kind of doing something weird, then you're going to want to count for a full 60 seconds and see if because you're going to need to tell what that is to your dentist or perhaps a doctor. Okay, so this would be taking a respiration rate on somebody. And you can see how she's pretending that she's taking the pulse. Quality, it should be quiet, automatic, effortless. Abnormalities usually involve effort or noise. Dyspnea, dys before anything, is difficulty. This is difficulty breathing, labored breathing, requires a lot of excess effort, usually requires oxygen. So noises it could make, stridor is a harsh sound on inspiration. They'll make this harsh crowing like sound, and usually they could have an obstruction. It's associated with breathing obstruction. Wheezing is a real high-pitched sound on expiration or inspiration, usually associated with asthma. And sometimes someone's giving sighs. I sigh a lot, but I don't have wheezing or stridor, just kind of release or something, but they claim that someone who sighs a lot, that you need to watch that has deep inspiration and prolonged expiration. Factors affecting respiration: age, medication, stress, exercise, altitude, if you're high up in the mountains, your gender, and body position. Temperature, measure of heat associated with your metabolism. Normal is 98.6. Taking a temperature. You need to know this word. This is going to come up often. Exia is also ia. Actually is at the end of a word, usually means blood. not all the time, but like 90% of the time. And in this case, like a pyromaniac is someone who loves to set fires. So pyrexia is a fever. It's when you get really hot, hotter than normal, and you have a fever, and it's a fever in the blood. So you can have infection, neurological disease, malignancy. You can have any one of those things to make a high fever. Then you have thermia. Thermia, Ia, once again, is the blood. Ther is for temperature. Thermia or therm. And hypo is less than normal. So you have less than normal temperature, blood temperature. And so that's a low body temp. They'll be shivering, cool skin, they'll have a pallor. Hypothermia causes illness, trauma, malnutrition, medications, and should refer to a doctor. So this is blood pressure. You need to know this. It's the force of blood that's exerted against the blood vessel wall on contraction. Okay, so the heart is contracting and it's squeezing. When it contracts, this blood goes out onto a blood vessel wall, and the force with which that hits the blood vessel wall is your systolic, the top number of your blood pressure. So systolic is the also the first sound that you hear when you're deflating the blood pressure cuff. Diastolic is the same thing, only relaxation. It's the force of the blood. Now your heart beats like this. So when it's contracting, that force of blood is going to be your systolic. When it's relaxing and it's kind of closed like this, that's the force of blood. It's coming out less, but still coming out. And it's the force of blood upon your ventricles of your heart, and when they're relaxed. So a lot of times your diastolic can mean kind of a bigger deal than your systolic, because if you're getting really high blood pressure when your heart's at rest, then maybe you need to see a doctor. Also, the diastolic is the last sound that you hear when deflating the blood pressure cuff. So pulse pressure is the difference between diastolic and systolic. So if your blood pressure was 120 over 80, you would take 120 minus 80, and that equals 40. And that goes there. So your pulse pressure is good because it's between 30 and 40. If it was 200 over 80, then when you subtract that, that is way off, and it would be, so that is indicative of an issue. And we don't ever really do a pulse pressure, but you need to know what it is. Okay, so different things affecting blood pressure, which is blood volume, how much blood that you have, because transfusions can increase blood pressure. Reduction in blood pressure would be if you're bleeding out, you've been shot and you're bleeding out this way, or you have a cut and you're bleeding out, or you're bleeding out and maybe one of your blood vessels burst inside of your body. And so blood's going everywhere. And of course, that's going to cause you to have low blood pressure. So that can affect your blood pressure. The viscosity, how thick it is. Viscosity means thickness. If you have increased thickness, it can cause the heart to contract more forcefully, increasing your blood pressure. It's doing more work. So if you take an aspirin, which thins the blood, then it can work less hard. So cardiac output, how much blood is actually being forced out onto the blood vessel wall, that can affect your blood pressure. Blood vessel resistance, if you have atherosclerosis, to where you have hardening of the arteries, and they're not elastic anymore, that it's going to be harder for when it hits. It isn't flexible and malleable, and it's going to increase your blood pressure. So the resistance, of your blood vessels. Your age, elderly are usually a little higher blood pressure due to atherosclerosis, and the gender, men and postmenopausal women usually have a little higher blood pressure. Stimulants, if you just drank a ton of coffee and smoked a lot of cigarettes or had anything with nicotine, and then take your blood pressure, it's likely to be higher than normal. Exercise. If you're a patient and you just walked up those 5 flights of steps because you didn't want to wait to go one at a time through our elevator at school, then likely their blood pressure could be higher than normal. So you would like wait and let them kind of calm down a little bit and sit there a little bit and then retake it. You'll probably get a more accurate. Individuals who consistently exercise, though, will, even if they go up those steps, will usually have a lower. They're just in better shape. And that's taking a blood pressure. So this is what happens when the cuff is on that right side. You can see that on the top, it's completely, you haven't started pumping yet. And so your blood in the middle is flowing straight through. Then you inflate that blood pressure cuff and it squeezes it to where you're having, it's very tiny. And so then as you gradually help deflate it again, then the blood starts kind of begins to open again. And that's when we can, we want to take the force of that blood pressure against the wall and how fast it's going out. But this is actually what's happening. So the process, you place the blood pressure cuff on, place the earpieces in your ears, facing toward with the earbuds, facing towards the tip of the nose. You're going to inflate the cuff with the hand bulb until you no longer feel a radial pulse. You're going to note the manometer reading and inflate always 20 to 30 milligrams per mercury higher. So what this does is it causes someone not to inflate way too high and squeeze the patient's arm. So the first sound is the systolic, the second sound is the diastolic, and any sound that you hear while you're taking the blood pressure is called a Korotkoff sound. This is the guy who decided that these needed words or needed the sounds themselves needed a name, and they're Korotkoff. So I'm going to stop here on this one because I want to go through in your book. You are going to see, I want to do this in the children, you're going to see these page and a half or whatever of all these charts on children. Don't even waste your time looking at those. You won't remember any of that anyway. What you need to know about children is that they determine blood pressure in children by their gender or their sex, age, and I thought I said, hold on a minute, is that correct? Yeah, okay. And height, not weight. So they determine, and they have all these formulas that they determine that by. But what you need to know about all of that is that they determine children by sex, age, and height, and that their normal range is in the 89th percentile and lower. I would know that, commit that to memory, and you don't have to bother with anything else. Couple things on the oxygen, just real quick. We kind of went over oh, I think we already did that with I knew there was something I wanted to point out, and that was it. On the oxygen, there's not much to that. So the class is actually over. So I don't mind completing chapter 3 if you want to hang, or you can, it's kind of the same thing on that recorded one that I gave. The same thing is in there. Or if you'd like, I can go through what pages that all these study guide questions are on. Anyone have a preference?
Can we do the study guide questions,
Yeah.
Pages.
please?
Okay. All right. So number one, I didn't have because I know you know that that's syncope. Number 2 is on page 2. 3 and 4 are on page 2. 5 and 6 are both on page 10. 7 is on page 5. 8 is on page 14. It's also on page 10 in table 2.1. 9 is on page 12. Page 3 would be 10 and 11. It might be in other places too, but those are. 12 and 13 you can get off of the PowerPoint. 14 is page 4. 15 is page 20, or wait a minute. Is that page 22? Sorry, I can't read my own writing. Yeah, page 22, table 3.1. 16 it says 22. 17 is page 36. I don't have one for 18, but you'll be able to see because of the charts. 19, page 31. 20, we just went over. 20 to 30 millimeters per mercury higher is the answer to that one. 21 is on page 27. 22, page 35 and 36. Also page 40. 23 is should be along with page 36 and in there. Number 24, we just went over the 8 factors that affect blood pressure. 25, you know, is green in 30 minutes. 26, when someone is an arrhythmia is your heartbeat, and when someone is going through cardiac arrhythmia, their heartbeat is irregular. You have an irregular heartbeat or irregular pulse. 27, page 35, table 3.6. I don't know 28, but it's that I don't know what page it's on, but you need to know their medical history. '29 is page 2. I want to point out one more thing before you guys go. In this book, they use the repair system, and all those letters stand for words. And at the end, like on page 40, they will, I don't know if you guys have your books or not. So on page 40, they have these. And after you get through this first section, there's going to be 1 or 2 of these at the end after the questions. You turn the page and like the in chapter questions, you'll turn the page and there will be this repair guide. And it takes you R for recognize, E for evaluate, P for position, A for activating, and I for actually implementing it, and then R for possible referral. But this will take you through a short little deal of what you do from top to bottom of an emergency. So I want to point out that that's there, and it will be there on the end of, so when you get to the next week, at the beginning of each chapter, there's going to be this scenario case study that they're making up, and at the end of the chapter, they'll have a resolution. But those are good places to kind of earmark. So are you good?
Yeah.
Yeah.
Do you want me to continue going the last of chapter 3, or are you good on your own?
So is everything that we like really need to take away gonna be on like the PowerPoints?
Some will be in the PowerPoints and some will be in the book.
Okay.
But I usually help you out a little bit there. The chapters are not that long. I mean, you can read the chapters so fast in these. It's just that every other sentence is kind of vital. So there's a lot of information packed in, 2 or 3 pages.
So
And the
on
quiz on,
is that PowerPoint already uploaded on Canvas or for us to
Yeah. They're already in, they've been in your modules, and
Okay.
I also have them recorded in your announcements.
and the quiz is chapters 1 through 4.
1 through 4, go by the study guide, and it will be next Friday.
Next Friday at the beginning of class, right?
What?
Next Friday at the beginning of class, right?
No, next Friday I open, you'll take it anytime you want
Okay.
during the day between 8 in the morning and 11:59 at night. We'll have regular class next Friday, going over the next 4 chapters.
Okay. Thank you.
Unless everyone takes it in the morning. If everyone takes the quiz, although next week we go back to our normal time that's on your schedule, which will be 9 o'clock. So if people take it before 9, I think there's 30 questions. If people take it before 9, then we could go over at our class time questions that you may have over it. If people choose to take it after 9, then we can't go over them on that day. We could the following Friday, but we can't go over them that day. Or you could email me questions that you have, and I could answer them like to a whole group. If you had questions, but if someone isn't taking it till 3 o'clock in the afternoon, we're not going to go over the quiz at 9, obviously. You get what I'm saying? But feel free to, you can take it at 10:30 that night. It's up to you.
And so those quizzes, they aren't open until Friday, correct?
Right. They'll be open and they'll be timed, and they're open anywhere from 8 in the morning till 11:59. And I don't have a preference of when you take it. So everybody in your class would have to have taken it if you want to go over a few questions. If you have questions about anything before 9 o'clock, before we have our meeting. But honestly, I don't think you'll have that much of a problem. Stick by the study guide, and I think you'll be fine. And then if there are some, I mean, I may have a typo in there, or do something like I did on this one question where I mixed up 2 different categories. If there's something like that in there, you can always email me and I can get back to the group. I won't be able to answer you though until the next day, because I'm not going to do it at midnight, and you probably won't want to look at it at midnight. But I will answer your questions the next day after everyone has taken it.
Okay, thank you.
So whichever way you want to do it. You guys have a great weekend. Stay safe.
You too.
Thank you. You too.
Okay.
Thank you.
Bye.